multi-drug resistance is a major global health problem. It occurs naturally, but the misuse of antibiotics in humans and animals can accelerate this process. It leads to longer hospital stay, it has higher medical costs, and it increases mortality in hospital patients. The WHO has set a plan trying to contain and reduce the spread of multi-drug resistance. That means that we are not alone. Multi-drug resistance is not a problem only for pancreatic surgeon, it's part of something bigger. This group of bacteria has been identified as the most frequent bacteria isolated with multi-drug resistance in hospital patients. It's called the escape group, like they escape to any traditional antibiotic treatment. If we look at the MDR-infected patients, a few factors have been identified as responsible for bad outcomes. And this is the result of a meta-analysis of 30 studies. These factors are Chelson cone, advanced age, inappropriate previous treatment, previous hospital admission, ICU length of stay, and the diagnosis of cancer. If we focus the attention to MDR infection and surgical patients, other factors have been identified as related to poor prognosis. Vasopressor use, mechanical ventilation, ICU, and in-hospital length of stay prior to the index culture, where the index culture is the first culture able to identify an MDR bacteria in hospital patients. Interestingly, they did not find any association with the prior use of antibiotic, which is a strange result, but maybe it's due to the low number of the two groups. I think we can all agree with the fact that the achievement of source control stands out as a critical factor for patient survival. Pancreatic surgery has not changed a lot during the past 30 years. It's a surgery with a high morbidity and mortality rate if compared to other visceral surgery. But in the past 20 years, the improvement in the perioperative care and in the supportive care has slightly reduced morbidity and mortality rate. Different factors are responsible for the outcome in pancreatic surgery, like body mass index, pancreatic texture, and recently advanced age and the presence of Escherichia coli in the bacteria of stented patient and the pre-existing diabetes have been associated to the increased risk of developing clinically relevant pancreatic fistula and associated to a risk of mortality rate. Gianotti, in this recent paper, when we meet together MDR infection and pancreatic surgery, we can see surprising results. First, he confirms that the preoperative biliary stenting is a risk factor for developing multi-drug resistant infection, but not only. The presence of different level of drug resistance in the bacteria isolated from these patients increases the risk of having even non-infectious complication in the postoperative course. A possible explanation is the persistent septic sources increase the metabolic demand and the substrate consumption of this patient in postoperative course, which may ultimately affect organ function. And do not forget that these patients are often a frail patient with a diagnosis of cancer, reduced functional reserve, sarcopenia, malnutrition, and other predisposing factors. The group of Verona with Matteo De Pastena confirmed the fact that the surveillance identified patients carrying multi-drug resistant bacteria in a rectal swab have an augmented risk of having infectious complication, sepsis, and they had an increase in the mortality rate. The aim of our study was to evaluate the surgical outcome after pancreatic resection in patients with a suspect of a diagnosis of cancer. In a colonized patient, the colonization was tested by the rectal swab. The secondary aim was to identify a risk factor for MDR colonization. The study was prospectively conducted in one high-volume single center, and all candidates for surgery for cancer were prospectively enrolled. Patients were screened with a rectal swab at day 0. If negative, they followed the traditional observation during the postoperative course, and we performed culture of a different site only if clinical suspicion was present. If the rectal swab was positive, patient underwent to physical isolation. Culture from drains were done from postoperative day 1, and in other side if clinical suspicion was there. And no specific antibiotic treatment was administered if no signs of infection were present. But this was something that we discussed a lot about, so we might discuss about this later. This is our standard attitude. The patients without a biliary stent received traditional amoxicillin and sulbactam before operation and every 4 hours. Patients with a biliary stent received piperacillin and tazobactam before operation and for 24 hours perioperative. And this is the result of a previous experience we had by isolation of the bile of patients who received a biliary stent before operation, we observed that the same bacteria isolated from the bile were present even in the drains in the postoperative course. So we decided to change the antibiotic prophylaxis in this group of patients. Data were prospectively recorded with attention to preparative risk factors, operative data, morbidity, fistula, infective complication, MDR infections, non-MDR infection, other complication, and mortality rate. This is the result of preparative data. No significant difference in age, body mass index, preparative markers, bilirubin. The significant difference was found once again in the biliary stenting before surgery. 90% of the patient positive at the rectal swab had received a biliary stent before operation. We couldn't highlight any difference between the way of insertion of the stent, endoscopic stenting or transhepatic stenting. We can highlight a trend, not a significant difference, and probably this is due to the low number of patients. In the neoadjuvant chemotherapy before surgery, this is a trend. 30% of patients positive at the rectal swab had received preparative chemotherapy. And this might highlight the fact that these patients are more frail as well. No significant difference in the operative data regarding operative time, blood loss, vascular resection, intraoperative transfusion, the pancreatic texture, the main pancreatic diameter. Here the histology, the postoperative histology, all diagnosis of cancer. Let's have a look to the surgical outcome, general surgical outcome. No significant differences in the clinical relevant pancreatic fistula, no differences in postoperative hemorrhage, no differences in delayed gastric emptying, and no differences in systemic complication after surgery. We did not find any significant difference in high-grade clavindinal complication. That means no differences in reoperation and in the interventional radiology procedure, and no differences in the median length of stay. But if we look at infectious complication in the postoperative course, we found a significantly higher percentage of infective complication in the patients positive at the rectal swab, 70% versus 32%. And the incidence of sepsis, isolation of MDR bacteria from drains and isolation of MDR bacteria from bloodstream was significantly higher in the rectal swab positive patients. There was a significant trend for the risk of developing these events with 3, 5, 14, and 11 times augmented risk for developing infective complications, sepsis, infected drains, and MDR in the bloodstream. We could not demonstrate a significant difference in mortality rate in the two groups. This is because probably the number of patients again, but we cannot highlight the trend. It's 4 times higher in the positive rectal swab group, the mortality rate, 20% versus 5.6. It is of interest that the bacteria we isolated in the group with positive rectal swab, the bacteria we isolated from the bloodstream and from drains were the same that in the patients were the same that we could demonstrate before operation or at time of the operation, present in the rectal swab or in the biliary stent. That means that these bacteria starts from a source and goes to the sensible surgical site. We could observe, even in the rectal swab negative group, a 7% of MDR contamination and infection of the abdominal drains, which is not negligible. 6 out of 90 patients had this kind of isolation. The bacteria were the same as the escape group, plus 1 candida resistant to fluconazole. And this was maybe even due to the fact that these patients were in the same surgical department as the other in the same period of time. I can conclude by saying that MDR colonization is significantly associated with postoperative infective complications. The preoperative biliary drainage is confirmed once again as a risk factor for MDR colonization. Data on mortality rate are not significant, but they show a worrisome trend. MDR infection can occur, of course, even in RS-negative patients. Physical isolation, education of surgeons, nurses, relatives, all the people involved in the management of these patients are essential to control the spread. The purpose can be to screen these patients before admission, so you can decide to target a preoperative specific antibiotic prophylaxis. By knowing this data before operation, we have to inform the patients of the augmented risk of postoperative events. What we would like to do, even if it's hard with the actual organization of surgical department, is trying to avoid unnecessary preparative drains. Thank you for your attention.
Thank you very much. The discussion will be led by Brian Goh from Singapore. The word is yours.
Do you want to come up here?
So thank you for your presentation. Just a short question. You mentioned that there was no effect of PTCD versus endoscopic drains. Did you have many PTCDs or was that just a few?
In a percentage, it's almost 20% of biliary drains.
Okay, thank you.
Okay, that was a nice talk. I think you are addressing a very important topic we are seeing worldwide now, the global epidemic of multi-drug resistant bacteria. I mean, right now in my institution, everyone who steps into the hospital will get a rectal swab, whether they're going for surgery or not. The number of isolation rooms are increasing. And I think in the near future, we may just simply isolate patients who do not have MDR, because there'll be more MDR than non-MDR patients. Okay, looking at your study, obviously, this is similar to the recent study from the Verona group, just published in HPB, although theirs had a larger population.
Yeah.
I think the main limitation, as you probably well know, is the small number of patients in your group, where you only just had 10 patients in the MDR group. And I think the main problem here is bias, because although when you look at risk factors, I understand you need to compare the two groups, but when you look at outcomes, there are a lot of biases between the two groups and confounding factors. For example, if you look at the baseline characteristics, although there was no significant difference, I saw that there was tended to be higher ASA score in the rectal swab positive group. They had higher biliary drainage. There were, all of them had Whipples, whereas on the other hand, the other group, there are some patients who didn't have a Whipples. All this will actually bias the results, and I think at least for the outcome analysis, you should do a propensity match study to correct for these confounding factors. Finally, I want to ask you a few questions. Firstly, you mentioned that 9% of patients with a rectal swab negative group have MDR, but what about those in the rectal swab positive group, how many of them had infections? It wasn't clearly mentioned. How many % of them had MDR infections?
Infections in general, I said this.
MDR infections in the
MDR infections was 40% sepsis, 50% MDR in the bloodstream, that means presence of MDR in the bloodstream, and 50% as well.
So the total outcome, or total number was?
The total number of MDR infections
yeah.
for this group of patients was 90%.
90%, okay. Second thing is, did you have data on patients who had rectal swab before they had surgery? So do you have a comparison?
We couldn't screen the patients before surgery. As I said, the screening was done at day 0. That means the day of surgery. The ideal setting would be having it done before.
So your institution doesn't routinely do rectal swabs?
We started with this group of patients because we had a sort of emergency period in our department. So for our unit, it's a recent procedure. 2 years ago we started. So the easiest way, because we are a referral center, so we have patients coming from other hospitals, the easiest way and the quickest way was to have the screening at the time of hospital admission. And we started that after 2 months' time that we had a spread of multi-drug resistant bacteria coming from these patients arriving from other places in Italy.
Dr. Nealon, on the right side.
Hello, hello. Still not working. Hello. Should I come up to?
Just speak up into
Okay,
it.
yeah, I have a good voice. So very nice paper. Yours is the most recent of many papers that have documented the infectious complications after placement of a biliary stent preoperatively for patients for pancreatic surgery. And I'm wondering if we've reached a point, and every surgeon knows that the operative bed is consistently more adherent in the hepatoduodenal ligament with the adhesions created by the inflammation from the stent. So I'm wondering if we're reaching a point where organizations such as this one might make a statement saying that this is not supposed, this is actually confirmed in many studies. And we all know that most patients come to us with a stent already in place. Is there a place for a formal statement that these data suggest that some changes in practice should be considered?
I think we need to get on the stage at DDW with the gastroenterologists. Is the best thing, but that's a very good suggestion. I'll ask one last question. You are presenting this about the multi-drug resistance, but it seems that you use some very powerful antibiotics at the outset. Could this be part of the problem? I think that it's not necessarily the standard to go with the highest level.
We arrived to use this powerful antibiotic because of a clinical need. What we observed in a 2 years period was that contaminating bacteria of the biliary tree found in the operative setting were the same responsible for infections in the postoperative course. So we had to focus, which is the purpose of this study as well, focus to MDR bacteria, and before was focused to not MDR but most frequent bacteria in the bile. And we had better results from when we decided to change the antibiotic prophylaxis. And we have just revised this setting with our infectious department, and they confirmed this trend. So at this time, we wouldn't change. For sure, the use of a strong antibiotic is one of the well-known factors for helping developing of the multi-drug resistance. But we have to balance risk and prevention.
Well, thank you very much. That ends this great session. Please go on.